Okay, so let's get started. Uh, okay, so today the discussion is going to focus on, sorry. So this is the last in the series of lectures on examination, physical science and interpretation of these physical science. And today we're going to talk about the upper limb and the lower limb examination. Okay, the neurological examination of the upper limb and the lower limb. Right, now again we start off with the examination technique. Okay, and for the upper limb and the lower limb, there is a common scheme of examination. So the themes that we use for examination are the same for upper limb and for lower limb. So it's easier to remember. The structure is different from the other systems, but the upper limb and the lower limb examination have a common theme. And obviously we start off with inspection, move on to examination of the tone, then the muscle power, then we go on to the deep tendon reflexes, coordination, sensory. And if you're examining the lower limbs, obviously examination of the gait is important as well. Okay, so these are the common themes of examination in the upper limb and the lower limb examination. Okay. Right. Now I will just go through the techniques with you. We start off with the lower limb examination and we'll move on to the upper limb later. So as I said first, the first thing to do is inspection. Okay, so lower limb inspection is the first thing to do. And here basically you are looking at any obvious wasting. Now remember that wasting will be very clearly seen in the thighs. So that is one of the important places to look for. Okay, and also if there's wasting in the lower leg, you will see a very prominent anterior border of the tibia. Okay, and that actually indicates significant wasting. If you see the prominent anterior border of the tibia, that indicates significant wasting in the legs. Also look for these movements that we call fasciculation, which are these muscle groups, sort of involuntary movements of the muscle groups and sort of muscle regions of the muscle. So that is also extremely important to notice. And again, the fasciculations are best seen in the large muscle groups, and this is including the thigh. Something that you have to be very careful of when you are inspecting is observe for any deformities, and foot drop would be an important deformity to look out for. Also look for small muscle wasting, especially in the feet, small muscle wasting in the feet. So very important. So inspection, look at the large muscle groups for wasting, look for fasciculations, look for deformities like foot drop, for example. Okay, and also look for wasting of the small muscles of the feet. All right. Now moving on, then you look for or examine the muscle tone. Now it's important to remember what the meaning of tone is. So tone is basically the resistance to passive movement. And I have demonstrated the proper way of examining the tone. Okay, proper way of examining the tone. And it is a resistance that you feel to your hands when you lift the foot off the bed. Okay, and remember, if the tone is exaggerated, the moment you lift it like this, the whole foot is going to fly off the bed. That is, if the tone is increased. Okay, if the tone is reduced, you will feel a very floppy limb. Okay, pananathua, just floppy limb if the tone is reduced. So basically examine the tone in the proper manner. Hurry. Moving on, if the tone is increased, then you have to additionally look for clonus. And I have demonstrated on the left side the proper way to look for ankle clonus. Okay, so ankle clonus, you lift the leg with your hand under the knee, slightly flexed as you can see in this picture, and then flick the ankle back. And if there is clonus at the ankle, you will see a sustained beat at the ankle. Usually more than 3 sustained beats at the ankle. Up to 2 can be normal, but if there is clonus, you will see a sustained beat at that point. On the right hand side, the picture on the right hand side, I have demonstrated how to look for patella clonus. And patella clonus basically is you push the patella down. Again, you keep your hand under the knee, flex the knee slightly, and then push the patella down. And you will see a movement of the patella up and down. This again is not a very common physical sign. Okay, But ankle clonus is a bit more common. So clonus, remember, is an upper motor neuron sign. We'll discuss about upper motor neuron signs as we go on at the latter half of the presentation. But clonus is upper motor neuron sign. So examine it only if you find increased tone. Right? So it is coupled with that always. Increased tone, increased reflexes. Clonus is coupled with that. Don't check for clonus if you think the leg is very floppy and flexy. So that is something which we look out for when you do the examination. නිකන් ඔහේ බලන්නම් වාලේ දේවල් බලන්න එපා. හරි. Now, unfortunately, there was a video here of clonus, which doesn't work like most of the time in PowerPoint, but that's okay. When you come to your appointments, you will see plenty of patients with clonus. Now, you might have already seen them during your neurology appointments. Right. Okay, so inspection, tone. The next thing to do is examination of the power. And in these pictures, I have demonstrated examination of the muscle power. Now remember, when you examine the muscle power, make sure that you examine the hip muscles, then the knee muscles, ankle muscles. So go down in sequence. And here I have shown you flexion of the hip, and just watch the pictures and just remind yourself of the technique. Right? This is extension of the hip and abduction and adduction. And again, I emphasize, I think you already know this, you should know the myotomes innervating these particular movements. That is extremely important. Okay. So flexion, extension, abduction, adduction. And you need to know what myotomes would innervate these various movements. Then moving on to the knee, flexion, extension of the knee. Okay. So this is extension and this is flexion of the knee. Compare the two sides as you go on. Right. At this point, I would like to make another important point. If you find that one side is abnormal, always start from the normal side. So remember, there are two sides in neurology. You have to compare the two sides. Always do the normal side first and then go to the abnormal side. So you're always comparing against the normal. These are little things, but critically important in your technique. Right. So knee flexion, knee extension. And then at the ankle, you're again looking at flexion and extension. This is basically, in other words, you call this plantar flexion and dorsiflexion. So plantar flexion, and now we are looking for dorsiflexion. Look at the proper technique of how to examine for dorsiflexion. Right? Okay. So then you can examine the big toe separately if you like. And then move on to inversion and eversion. You can examine the dorsiflexion of the big toe separately if you like. Might be relevant in some cases. But here, then you look for inversion and eversion. Do not forget the inversion and eversion. And later on, when you come to your professorial appointments, you will realize that in a patient with foot drop, and you might already know this, these two movements are very, very important. These two movements, inversion, eversion. So make sure that you do those routinely in everybody, otherwise you forget. So at the ankle, there are actually four movements. You have the plantar flexion, the dorsiflexion, and then the inversion and the eversion movements. And then I have given you a list of the myotomes for the lower limbs, and make sure that you remember all of this. Okay, this is very, very important. You won't be able to work out anything without knowing this. So again, recapitulating, you have inspection, tone, power. Then obviously you go to the reflexes. Okay, so reflexes, you are looking at the knee reflex. Okay, knee reflex. And this is the proper way. Make sure that you ask the patient to bend the leg properly, relax, and then tap the patellar tendon. First, feel the patellar tendon. Make sure that you localize it nicely, and then give it a tap. Okay. Then the ankle reflex is the next thing to look for. And then the plantar reflex. Again, there's a video. I'll try to get hold of these working videos and I'll share it on Classroom. So the plantar reflex, as you know, there are several components of the plantar reflex. So write this down if you don't know. first you have extension of the big toe. Then you have, this is a extensor plant response. So there are three components of an extensor plant response. You have the big toe extension, the fanning out of the other toes, and then also there is another interesting thing that you see. There is this aponeurotic tendon here called the tensor fascia lata on the lateral aspect of the thigh. You see contraction of that tendon as well. So there are actually three components of the extensor plant response. So the big toe going up, toes fanning out, and also contraction of the tensor fascia lata. In people who have a very significant upper motor neuron pathology, you will get all three. And so therefore it is also possible to examine a plant reflex even if the patient doesn't have any toes, because then you can obviously look at the tensor fascia lata. So there are three things that happen when you have an extensor plant response, which is a very good upper motor neuron site, very hard objective upper motor neuron site. Okay? So make sure that you look at it carefully. Right. So inspection, tone, power, reflexes. Then we go to coordination, usually done by the heel-knee shin test in the lower limbs. Now, also remember, if the patient has any weakness of the legs, it might be difficult to comment on coordination, because if you imagine, if the legs are weak, the coordination might be abnormal, but that's not because of the cerebellar disease. It might be because of just because of the weakness. Okay. So in a weak leg, coordination might be difficult to comment on, because as you know, coordination is looking at the cerebellar function. So, but make sure that you do this routinely, and just if the leg is weak, then you need to take it carefully, interpret it carefully. Hi. Then sensory, you have to know the sensory dermatomes. Like the myotomes, the dermatomes are also very, very important to know. Harine. Okay. And the joint position sets. Okay, so just running through that again, Lamai. Common scheme of examination for lower limb and upper limb: inspection, tone, clonus in patients who have exaggerated sort of increased tone. The power, examine the power around all the joints, hip, knee, and ankle. Okay, hip, 4 movements at the hip, 2 movements at the knee, flexion, extension, and then 4 movements at the ankle, including the inversion and the eversion. Remember the myotomes, reflexes, plant reflex, extensor plant reflex is a very hard, firm upper motor neuron type sign. So therefore what happens there is extension of the big toe, fanning out of the other toes, and contraction of the tensor fascia lata. And the coordination, heel-knee shin test. Finally, you have your sensory. And in the lower limb examination, remember, end of the lower limb examination by looking at the gait. You can do that at the start as well, or you can do it at the end, no problem. But remember to examine the gait. So, since in the upper limbs, again, the Katandari is very similar. In the upper limbs, again, look for wasting fasciculation. Now, very important, when you are doing upper limb examination, make sure you expose the patient properly. Upper limb can ata vitarak newe, you have to look at the shoulder region back as well when may hari. And sometimes wasting fasciculations are best seen in these two areas here. So make sure that you take a little bit of time and care when you're doing the examination. So make sure you expose the patient properly and inspect very carefully, including this back, shoulder, and sort of posterior aspect. So look for the usual things: wasting, fasciculations, wrist drop would be obvious if it's a upper limb that you're doing, and these other deformities like clawing of the hands, small muscle wasting, wage dewa. I have demonstrated in this picture another important thing on inspection, which is unique to the upper limbs, and this is what is called pronated drift. So pronated drift, when you ask the patient to stretch the hands out like this and close the eyes, what happens is, if there is pronated drift, one hand will pronate and fall. And this is seen if there is upper motor neuron type weakness in the limb. So this is called a pronated drift, very specific thing. the hand pronates and falls. Okay, and that is a very good sign of an upper motor neuron type lesion of the upper limbs. You see this very commonly in stroke, and it's actually a very good screening test for stroke. And look for this mild hemiparesis. So pronated rift, write that down. And this is a picture of a patient with small muscle wasting. You can see a lot of small muscle wasting, and this dorsal guttering. This is called dorsal guttering, and you can see this prominent extensor tendons on the dorsal aspect of the hands, and you can see wasting of the thenar, hypothenar eminence, and also clawing. You can see these fingers are clawed. So this is a very good example of small muscle wasting, and also small muscle wasting and clawing of the hands. Again, there was a video here. I'll make sure that I get these videos uploaded. This is a video of fasciculation. Okay. Fine. Then you examine the tone. So examination of the tone is easy around the wrists, a circular movement around the wrists. Okay. And just observe for the resistance of movement. You might also feel this cogwheel rigidity when you do the wrist round like that. Cogwheel rigidity is very simple. It is just rigidity and that tremor, super added tremor. Right, like a sort of bicycle cogwheel where the resistance increases and decreases. Okay, increases, decreases, increases, decreases. That's called cogwheeling rigidity. So you can examine that in this manner. And then you can also, if you like, you can examine the tone around the elbow like this. So inspection, tone. Remember, we are following the same scheme of examination, like in the upper limbs, inspection, tone. Then you go to power. So power, the upper limb, there are several movements that you need to do. So what I'm first doing is the first 30 degrees of abduction at the shoulder. Again, we are sticking to the key joints. So abduction at the shoulder, 30 degrees, the first 30 degrees, and then the complete abduction of the shoulders. The first 30 degrees of abduction is by the supraspinatus muscle, and the rest is by the deltoid muscle. So that's why you have to do both. Abduction of the upper limbs. Adduction of the upper limbs. Relatively, I would say this is not very important because it doesn't have a very good localizing value, but abduction is very, very important. Now, this movement is also very important. Why is it important? We are looking at the long thoracic nerve and the serratus anterior. And if it is weak, you are going to get winging of the scapula. Okay, you are going to get winging of the scapula. When you push the scapula, okay, winging of the scapula. And what is this movement that I'm checking? So I basically asked the patient to do that and push back. So, like chicken wing movement, and then move it back. Again, that is a special movement. We are examining the rhomboids. Okay, rhomboids. Okay, rhomboids. And the nerve is the nerve to rhomboids. Then very few people appreciate this fact, and this is very, very important. When movements are exceptionally important in the upper limb examination. Okay. Now you're doing the shoulder. Remember, you need abduction. Adduction is less important, I would say. But here you're doing the serratus anterior muscle and the rhomboids. Now there is a very important reason why these two muscles need to be checked. These two muscles need to be checked because of a very specific reason. Now, a reason, if you revise your anatomy or go back several years into your anatomy classes, they would have taught you that the nerve to rhomboids and the long thoracic nerve are given off before the brachial plexus. Okay, so these two nerves are given off before the brachial plexus. So if it's a brachial plexus injury, these two nerves will be preserved because these two nerves are given off before the brachial plexus. So that's a very, very important point. Please write that down somewhere because that is going to be useful and very important when you come to your final years, and we will discuss a little bit more detail about these movements and how they are important. At the moment, remember, these two movements are important because they are given off, these nerves are given off before the onset of the brachial plexus. Okay. So please write that down. And they will be important. We'll teach you. So this is just, you are going into a second appointment when you come to your final years, you will obviously learn more about this. Then in the elbow, it's just flexion and extension. Wrist flexion extension. Make a tattak gala karanna puluwan wenna because upper limb examination can take a little bit more time. Okay, so be careful, time yourself, but this will come with practice, don't worry. Okay, I'm just checking the flexion of the fingers there. And then now we are checking the small muscles of the hand. So small muscles of the hand, remember, it's always abduction, adduction. You know the muscles and the movements, pad and dab. Okay, palmars adduct and dorsal interossei abduct. So this is important. So as I told you, for the lower limbs you need to know the myotomes. For the upper limbs you need to know the myotomes and also a little bit of the muscles which are involved. Okay, especially the small muscles of the hand and what they do. Okay, so dorsal, palmar interossei, what they do. So I'm checking abduction of the fingers and adduction of the fingers. And this I am checking the adductor pollicis brevis, which is a small muscle there. It is supplied by the ulnar nerve. Okay. And this is the thumb movements now. Opposition and flexion of the thumb. Now, all these small muscles are supplied by the root T1, myotome T1. Okay, so palmar abduction, adduction. You checked the adductor pollicis brevis and the flexion and opposition of the thumb. All of these are supplied by the T1 myotome. All the other myotomes are given in this picture, so you can understand a little bit more. Okay, but for each of these, upper limb, lower limb, detail you need to know muscles and nerve supply and everything. Okay, so please study ulnar nerve, what the ulnar nerve supplies, radial nerve, what the radial nerve supplies, and the median nerve, what is the basic anatomy that you were taught in your first year. Okay, but you need to know that, retain that, because when you come to your cases and when you come to your final years, you will be asking questions about this. So high time to just read a little bit about this and refresh your memory. That is your second point. Reflexes, just observe in these pictures the proper way of examining the biceps reflex, okay, and the proper way of examining the biceps reflex, okay, and the triceps reflex, and then the supinator reflex. Okay, hari lamai. Then, so we have done the inspection, tone, power, reflexes, and then we go to coordination. So coordination is basically by the finger nose test. Okay, so finger nose test. That's how you check for coordination. Okay. Again, the same principles arise in the lower limb, like same in the upper limbs. If there is weakness on one side, the coordination might be abnormal. But that is not due to a problem of your cerebellum. It is because the arm is weak. So be careful when you interpret these physical signs. Okay. And then in the sensory examination, like in the lower limbs, you need to know the dermatomes of the upper limb. So what dermatomes are involved and how you would map these dermatomes out. The පාඩම් කරගන්න ටිකක් තියෙනවා when it comes to limbs, you need to know the myotomes and the dermatomes for upper limb and lower limb. And for the upper limb, lamai, poddak a little bit more detail about the muscles, especially the small muscles of the hand, their nerve supply. In addition. Hari? Okay. Fine. So now I give you a little bit of time to ask questions. Okay. Before we go on to interpretation. Now, පොඩි එකාට හොඳට මොලේ තියෙනවා මම අර Alexa speak එක unplug කරලා මොකද plug කරගෙන ඒකට එක එක කියනවා. Right, good. Right, so here's some brains and IQ. Fine. So can you explain the components of the supinator reflex? So supinator reflex, lamai, what happens is the supinator reflex is when you hit the supinator tendon, what happens is the fingers flex, okay, fingers flex. There is a slight movement at the wrist. Okay. Slight extension at the wrist. And flexion at the elbow. Okay. Slight extension at the flexion at the wrist and flexion at the elbow. So watch me. When you hit it there, flexion there, and then yes, that's what happens. Inverted supinator reflex, I will leave it for the moment. Basically, invert supinator reflex. Supine reflex, watch this again. When you hit it there, flexion of the fingers, slight upward movement at the wrist and slight upward movement at the elbow. Inverted supine reflex, the common case that you get is when you hit it there, you just see flexion of the fingers. Yeah, with the right hand. None of the other movements are present. Okay. Then, in the extreme instance of an inverted supine reflex, when you hit it there, it goes the opposite way completely. Opposite way, it goes the other way, right? Where the whole thing is extended. So there are two types of inverted supinator reflexes. Okay, two types of inverted supine reflex. One is the only movement you get is just the flexion of the fingers. But in extreme situations, when obviously it's a very advanced pathology, inverted supine reflex it goes the other way. So you get extension of the hand upper. Okay. We know, yes, you should examine gait as a lower limb exam. I thought I mentioned that when I was talking about that. Okay. Fine. Ask a few more questions. Ani Baba, can you go to the other room? Can I give the Alexa to the other room? Okay. Come. That is working, Baba. Please hurry there. You play with Alexa then. Okay. Fine. Good. Right. So, Sachit, do we get to examine specific joints in medicine? Very unlikely. Surgery will now shoulder joint, knee joint, but medicine will saman in the there is a different small joint examination which is useful for rheumatoid arthritis. Again, you learn in your final year. Don't worry about that. And we'll talk about the cerebellar signs later. That's fine. Okay. Then right? Okay. Now, so I've just gone through with you the technique of examination, which is just a revision for you. What follows next is far more important now. Now, when you finish the examination, upper limb or lower limb, your main target is to classify the physical signs that you get. To classify the physical signs that you get into one of these 5 categories. So the first step is to characterize or classify the physical signs that you get to one of these 5 categories which I have shown on the slide. Very, very important. Make any questions, please put them immediately, then I will answer them immediately. The first step is to do that. And why are we doing this? Again, I remind you of the session we had yesterday. Why you are doing this is basically to answer 2 questions. The first question is, where is the lesion? Second question is, what is the pathology or what is the lesion? Now, you have to classify your physical signs into one of the following groups. What are the main groups? 1, all your findings are upper motor neuron type. So, upper limb, lower limb, examine kalla. All the findings that you detect are upper motor neuron signs. That's one package. There are 5 packages. Then, number 2, all the findings you get are lower motor neuron signs. Third, you get a mixture. upper motor neuron signs plus lower motor neuron signs. ඒක වෙන්න පුළුවන්. Then you get extrapyramidal signs like Parkinson's වගේ. Extrapyramidal. So Parkinson's, you have seen patients, you have had lectures, right? So you know that tremor, that rigidity, that mnemonic that you have been taught, TRAP, T-R-A-P. So when you examine the patient's upper limbs, you will get that cogwheel rigidity and the tremor you will see. So are these extrapyramidal signs? Are these cerebellar signs that you get? So you have 5 categories. So when you finish your examination, you should be able to classify, all right, this chap has a pure upper motor neuron type syndrome. All right. Examine another patient. This patient has a pure low motor neuron type syndrome. That's your start. Another patient might have a mixed upper motor neuron, low motor neuron syndrome. The next patient might have extrapyramidal type signs. And the other patients, another patient might have cerebellar. So you need to package your signs into these categories. Okay, so that is the first step. And all of you should now revise the differences between upper motor neuron and lower motor neuron, which I will tell you now. If you don't, please write this down if you don't remember. So upper motor neuron versus lower motor neuron. Lower motor neuron, you get a lot of wasting and fasciculations, which actually corresponds to the level of weakness that the patient has. So the level of weakness and the wasting and the sort of thing they go hand in hand. So they have wasting, they have fasciculations, and this corresponds with their degree of weakness. The difference in upper motor neuron syndrome is they get very minimal wasting. Very wasting in no fasciculations at all, but they can get a bit of wasting. Why? Because with time, what happens is they get disuse atrophy. So they get minimal wasting, no fasciculations, and this wasting does not match with their degree of weakness. Definitely not. They go weak, but they don't have a lot of wasting. Whereas in the lower motor neuron syndrome, a lot of wasting, fasciculation, and that is equal to their weakness level. First point, that is the first point. Second point is a bit specific for your upper motor neuron syndromes. They have a very specific pattern of weakness. Pattern of weakness. And try to find out the basis for that. So what is this pattern of weakness that I am talking about? In the lower limbs, flexors are weaker than extensors. So please write that down. In an upper motor neuron syndrome, in the lower limbs, flexors are weaker than extensors. Flexors are weaker than extensors. Okay, reverse second upper limb. Reverse second upper limb. So in the lower limb, flexors are weaker than extensors. Reverse is true for the upper limb. So this is a specific pattern of weakness or upper motor neuron pattern of weakness. Lower motor එකේ එහෙම විශේෂත්වයක් නැහැ. Flexors and extensors are equally affected. There is no difference. Third point. In upper motor neuron lesion, you know that the reflexes are the tone is exaggerated. The tone is exaggerated or spastic. Lower motor neuron, you know that the tone is flaccid or reduced. That you already know. Then the fourth point is reflexes are brisk in upper motor neuron lesions. Plantars are extensive. In lower motor neuron syndromes, the reflexes are diminished or absent. And plantars are flexor. Okay. So reflexes are exaggerated or brisk. And the plantar is extensive. The last point, Lama, is there are a set of reflexes that are preserved in lower motor syndromes but absent in upper motor syndromes. ඒවා අහලා තියෙනවද? මම දන්නේ නැහැ. Now, usually when reflexes are brisk in upper motor neuron, but diminished in lower motor neuron or absent in lower motor neuron, there are a set of reflexes that are absent in upper motor neuron. And those are called the superficial abdominal reflexes. So for interest, please find out how you elicit those, and I will teach you later when you come to your final year. Okay, but remember, there are a set of reflexes that are diminished in upper motor or lost in upper motor neuron type lesions. So these are the differences between upper motor neuron and lower motor neuron. That should be in your head very, very clear. So wasting fasciculations in lower motor neuron, minimal wasting. Specific pattern of weakness in upper motor neuron, no specific pattern in lower motor neuron. Tone is increased in upper motor neuron, tone is reduced in lower motor neuron. Reflexes are brisk, planters are extensor, reflexes are lost in lower motor neuron. And there are some reflexes which are absent even in upper motor neuron, and those are called the superficial abdominal reflexes. So first step is basically when you finish your limb examination, try to package your physical science into one of these 5 packages. Very, very make a final I will again revise this, but very quickly. So you will just need to study this now and practice this. Right. Now, I will just skip this slide and go to this first. Now, say for example, you get a lower motor neuron type syndrome. Lower motor is very, very important. Lower motor. The lower motor neuron kiyane mokadda? Starting from the anterior horn cell to the muscle. So if we go in reverse, okay, you have the, what are the components of a lower motor neuron pathway lamai? Muscle, right there. Then you have the neuromuscular junction. Okay, so the muscle, the neuromuscular junction, right there. Then you have the nerves there. These nerves come together to form plexuses and roots. And they end up in the anterior horn cell of the spinal cord. Then what are the components therefore of a lower motor neuron pathway? You have the, now just look at the headings in this table now. So you have muscle, neuromuscular junction, peripheral nerve. And there are various types of peripheral nerve lesions that we are going to talk about. Peripheral nerve. Then these nerves combine to form plexuses, roots. Root can example like a C6, C7. That's a root. Roots. And then you have the anterior horn cell. Anterior horn cell. The spinal cord. So this is the lower motor neuron pathway. Muscle, neuromuscular junction, peripheral nerve, root, plexus, anterior horns. Then මේ table එක ඔයගොල්ලන්ට කටපාඩමින් දැනගන්න වෙනවා. Also please understand this. There are very characteristic features of a lesion in these areas. Then බලන්න මම පොඩ්ඩක් ආයි පිටිපස්සට go one step back. You have examined the lower limbs. First thing is you put it in your package. The package that we are talking about here is the lower motor neuron package. Then, when you say, this is a lower motor neuron package, you need to next figure out whether it is a muscle lesion, neuromuscular junction lesion, peripheral nerve lesion, plexus lesion, root lesion, or anterior horn cell lesion. To do that, you have to understand the features of a lesion in any of these places. මේ තැනක තියෙන lesion එක features දැනගන්න ඕනේ. Okay, features දැනගන්න ඕනේ. Let's start with muscle. And තේරුණාද මේ flow එක? So first identify the package. Now we are dealing with a lower motor neuron package, and then within that package, now we are trying to say make a muscle, the neuromuscular, the nerve, the root, the mukadda kila, we are trying to figure out. Right. And there's a pattern for each, and that is pattern recognition from this point onwards. Muscle. What are the features of a muscle lesion? Muscle lesions are always bilateral and symmetrical. Then balanna me table එකේ ළමයි. oops, just give me a second. May table එකේ පළවෙනි column එක. There. Muscle. Remember, myopathies or muscle lesions are always bilateral and symmetrical. Bilateral and symmetrical. If you take the weakness, usually, in 99% of the time, it is proximal weakness, which is more. Proximal weakness can thighs in the legs or shoulders in the upper limbs. So it is almost always, or say 99% of the time, proximal more than distal. Very, very rarely there are distal myopathies as well, but those are too much for you at the moment. So what is the pattern of weakness or distribution of weakness? Bilateral, symmetrical, proximal more than distal. Do you get wasting in muscle lesions? No, not very commonly. Minimal wasting. Sometimes in pediatrics, you might see are Downs Duchenne's muscular dystrophy, calf muscle can get pseudohypertrophy, for example. So some of the muscle lesions, because of fat deposition, the muscle might look bigger. Wasting is very unusual except in the later stages of the illness, very advanced illness. Similar reflexes. Muscle එකක reflex එකට සම්බන්ධයක් නැහැ. Reflex is nerve. It's a neural arc. So reflex is preserved, but with time, when the muscle becomes smaller and smaller, it might diminish. Okay, and that is again mostly proximally rather than distal, because the involvement is more proximal in these patients. Will there be sensory loss in a patient with a myopathy? Definitely no. There will be no sensory loss. So what is the pattern then, api lamai? Muscle lesion, so lower motor neuron type lesion, muscle lesion, bilateral, symmetrical, proximal more than distal. Minimal muscle wasting, reflexes are preserved. They can be diminished, but they are not absent. Okay, and there is no sensory loss. The key thing here being proximal weakness, which is bilateral symmetric. That is a myopathy unless proven otherwise in your lower motor neuron syndrome. ඊගාවට neuromuscular junction. Now, එතන පොඩි point එකක් ඉගෙන ගන්න ඕනේ. Neuromuscular junction lesion doesn't follow the common pattern of lower motor neuron syndromes. Right? As you can see, wasting නෑ, reflexes මුකුත් වෙන්නේ නෑ. The key thing in a neuromuscular junction lesion is it causes fatigable weakness. Fatigable weakness. The more they move the muscle, the weaker it becomes. So there is myasthenia gravis, for example. ඒක ගැන එච්චරයි අපි ඉගෙන ගන්න. Fine. Okay. Third thing. Now, peripheral nerve. Now there are various patterns of peripheral nerve lesions. One type is a polyneuropathy. Polyneuropathy කියන්නේ multiple nerves involved. Polyneuropathy කියන්නේ multiple nerves involved. Mononeuropathy කියන්නේ one nerve involved. Mononeuritis multiplex කියන්නේ just a patchy involvement of many nerves. A patchy involvement of many nerves. ඒ දෙක අපි දැනට පොඩ්ඩක් පැත්තකින් talk about a polyneuropathy pattern. Now remember, polyneuropathy pattern. Polyneuropathy pattern is the classical low motor neuron presentation. Polyneuropathy වල pattern එක, look at this table now, this column. Polyneuropathies are almost always bilateral and symmetrical. Number one. Most of the time, distal more than proximal weakness. Most of the time, distal more than proximal weakness. There are exceptions. For example, Guillain-Barré syndrome, which is a demyelinating neuropathy, there is predominant proximal weakness or proximal and distal weakness almost at the same time. But most neuropathies will be distal. Now, muscle එක මොකක්ද කිව්වේ? Proximal වැඩි නේද? Neuropathies, polyneuropathies are mostly distal predominant. Distal predominant. So write that down. Wasting again follows that pattern. You will definitely see wasting in neuropathies. Definitely. And this wasting again is predominantly distal. Wasting is predominantly distal. Predominantly distal. Got it. Reflexes are absent. Anivaryeng reflexes get affected. There is no bloody doubt about that. they are significantly diminished or absent. Most of the time they are absent. So in a polyneuropathy, one of the cardinal features of a polyneuropathy is the loss of reflexes. Loss of reflexes. And then finally, sensory loss is again distal predominant. Sensory loss is distal predominant. Distal predominant. So it has sort of a length dependent pattern. Longest nerves are affected first. That is a length dependent pattern. So polyneuropathy is distal predominant, more than proximal. Okay, reflexes being absent, bilateral symmetrical. Reflexes being absent are one of the key features that you see, right? And the sensory loss is also length dependent, and they get distal sensory loss first. Right. Now, the other types of neuropathies, mononeuropathy is easy because from your anatomy days, you know this. Mononeuropathy will always have a neural distribution of motor and sensory involvement. For example, ulnar nerve එක ගියොත් එහෙම sensory loss will be in the ulnar nerve distribution only there. And the weakness will be predominantly in the small muscles of the hands supplied by the ulnar nerve. So that is called a neural distribution. It's called a neural distribution. A nerve එකෙන් එළියට එන්න බෑ. So if you diagnose a mononeuropathy, the weakness and the sensory loss should correspond to that nerve. එතනින් එළියට එන්න බෑ. පනින්නම බෑ. Right? So make sure that you know that distinction, differentiation. So it has a neural distribution. Mononeuritis multiplex is sort of a patchy collection of multiple mononeuropathies. හරිම asymmetrical එකක් එන්නේ. Asymmetrical එකක් එන්නේ. Right. Fine. හරි ළමයි අනේ මට පොඩි දෙයක් කියන්න අමතකුණා neuromuscular junction එකේ ලියා ගන්න ඔය මේ table එකේ bilateral තියෙන තැනින් asymmetrical කියලා තියා ගන්න. Because neuromuscular junction diseases are bilateral but they are frequently asymmetrical. Non-symmetrical. මේක පොඩ්ඩක් දාගන්න එතන මේකේ table එකේ නෑ ඒක. හරි. So low motor neuron package, we are doing further analysis now. Muscle lesion දැන් ඔන්න ඔක්කොම කටපාඩමින් මොලේ ඇතුලේ තියෙන්න ඕනේ. Bilateral symmetrical, proximal more than distal, minimal wasting, reflexes are preserved usually until the later stages of the disease, no sensory loss. Neuromuscular junction lesion එකක් නම් මොකද්ද pattern එක? Bilateral but non-symmetrical or asymmetrical, and then they have fatigable weakness. Sorry, fatigable weakness. Polyneuropathy is bilateral symmetrical, distal more than proximal, and sensory follows that pattern, and then we'll also have absent or significantly diminished reflexes. Mononeuropathy will always follow a neural pattern. ඒ nerve එක දිගේ එළියට පනින්න බෑ. ඒ nerve එක දිගේම තමයි යන්න ඕනේ. Mononeuritis multiplex is a patchy collection of multiple mononeuropathies. දැන් මම එකක් පැනලා root වලට යනවා ඉස්සෙල්ලා. Okay? Root lesion, take for example T1 root lesion. Root එකම ගිහිල්ලා spinal cord එකකින් එළියට එන. A root lesion, now is told that a nerve has a neural distribution. Neural, ඒ කියන්නේ nerve එකේ muscles, nerve එකේ sensory, neural distribution of neurology. A root lesion has a myotomal and dermatomal distribution of neurological impairment. ඒ කියන්නේ මොකද්ද? Myotomal, dermatomal කියන්නේ in a root lesion, the myotome supplied by that root සම්පූර්ණයෙන් යනවා. If it's T1 root, then ate small muscles, for example. Myotomal, and the next word is dermatomal. Dermatomal කියන්නේ a T1 dermatome එක යනවා. T1 dermatome එක යනවා. So that is the description of a root lesion. Myotomal, dermatome. Reflexes will also be affected in that pattern. Reflexes will also be affected in that pattern, myotomal pattern. Okay. For example, if it's a L5S1 root lesion, the ankle reflex will go. So myotomal, dermatomal, and reflexes all will follow that root pattern. Okay. A plexus lesion is a collection of multiple root lesions depending on where you're talking about. Right? Upper limb, all over. And remember, we will talk more about root lesions in your final year. It's a bit complex sometimes. Plexus lesions and multiple root lesions, a bit complex. But at the moment, just remember, plexus lesion is a collection of multiple roots involved, depending on what plexus you're talking about. The last one is anterior horn cell lesion, and you know this commonly as motor neuron disease. Now remember, motor neuron disease can anterior horn cell එක විතරක්ම යන්නේ නැහැ, ඒකේ වෙන වෙන තැන්ුත් යනවා, but obviously anterior horn cell is significantly affected. If it is anterior horn cell lesion, the lesion is always bilateral, but again it is non-symmetrical, asymmetrical. දෙපැත්ත වෙනස්. හරි, දෙපැත්ත වෙනස්. And usually proximally predominant. The key thing, the very important, in anterior horn cell lesion, the key thing is they have very, very prominent fasciculations. In anterior horn cell lesion, the key feature is they have lot of fasciculations and wasting as well, but our fasciculations are very, very prominent. Obvious, fasciculations peenawa. And that is a very prominent feature of anterior horn cell lesion. So bilateral symmetrical, proximal predominant, wasting, and very, very prominently fasciculations. The last thing you have to remember is anterior horn cell lesions are part of this big process of motor neuron disease. There are other ones like, for example, polio or spinal muscular atrophy is a pure anterior horn cell lesion. But in adult medicine, anterior horn cell lesions are usually due to motor neuron disease. So the motor neuron disease, it involves the whole motor path, including the upper motor neurons. So I'm going to give you a very important point. Again, these are called pearls of neurology. In anterior horn cell lesions due to motor neuron disease, they might get a mix. Mixed pattern. So this mixed pattern is classically seen in motor neuron disease. Classical example is upper limb exam එකට wasting තියෙනවා, fasciculation ඔක්කොම තියෙනවා. අපි හිතන්නේ දැන් මේක low motor neuron package එකට දාගන්නමයි හිතේ. But when you examine the reflexes are exaggerated as well. And that is most likely due to then therefore motor neuron disease. So you can get a mix. And will you ever get sensory loss in an anterior horn cell lesion? You will not, because the sensor is always through the posterior root of the spinal cord. කවදාකවත් anterior ගෑවිලා වත් යන්නේ නැහැ. So anterior horn cell is always only motor. Sensor is perfectly normal. ඔය කියන හැම වචනයක්ම වැදගත්. Every word I have uttered on this table is exceptionally important for you. හරි? Okay. So that is that. So when you have upper limb or lower limb examination, your first objective is to package it. Upper motor neuron, lower motor neuron, mixed extrapyramidal or cerebellum. If it's a lower motor neuron, you need to be more specific and tell the examiner or make a diagnosis saying, could this be a muscle lesion? Could this be a neuromuscular junction? Could this be a polyneuropathy? Could this be a polyneuropathy? Could this be a plexopathy? Could this be a root lesion? Could this be an anterior horn cell lesion? To do that, you should know the patterns of each of these types of lesions. So when you see a patient, reverse checking, diagnose karaganna puluwan better. So then just close your eyes and revise this now. So myopathy, what are the patterns? Bilateral, symmetrical, proximal more than distal, minimal wasting, no fasciculations, reflexes preserved, no sensory loss. That's a myopathy. Get that pattern into your head. Neuromuscular junction, bilateral, asymmetrical with obvious fatigability. Right. Polyneuropathy, bilateral, symmetrical but distal predominant. Reflexes are absent or significantly diminished. Sensory loss predominantly distal. Right. Hari. That is the pattern. Right. Sachit, what is the reflex rate in your neuromuscular junction? Usually it is normal. Okay, usually normal. But in an attack, say for example, in a myasthenic crisis, it can diminish, but usually they are preserved. Right. Motoneuropathy, neural pattern. Nerve distribution only. Motoneuropathy, collection of multiple nerve lesions. Patchy, asymmetrical. Root lesion, myodermal, dermatomal reflexes in that root only are affected. Plexus is a combination of roots. Anterior horn cell, bilateral but non-symmetrical or asymmetrical, proximal predominant. Key feature is fasciculations, no sensory loss. Because in adults, anterior horn cell disease is part of the spectrum of motor neuron disease, they get a mixture of upper motor neuron, lower motor neuron size. Classically, wasting fasciculation with brisk reflexes, but no sensory loss. Very, very. I hope that you got something into your head. There is time for you to learn this. Professor Renokota, make sure that you remember everything that I have just mentioned. Now, the last thing that we are going to discuss is the upper motor neuron package. Upper motor neuron package. Now, upper motor neuron package can present in 3 ways. Write this down. Number 1, hemiparesis. Upper motor neuron type hemiparesis. Lesion is usually due to a stroke in the opposite side. So one type of upper motor neuron weakness is hemiparesis, very easy, stroke in the opposite side. Katandare kelevara ivara. For undergraduates. For postgraduates. The next pattern is paraparesis. Paraparesis කියන්නේ මොකද්ද? Paraplegia කියන්නේ මොකද්ද? Weakness of the lower limbs. Okay. Quadriparesis or quadriplegia is weakness of all 4 limbs. Weakness of all 4 limbs. Weakness of all 4 limbs. So, a pattern tuna තමයි තියෙන්නේ. Starting off with number 1, we talked about hemiparesis due to a stroke. No problem. Upper motor neuron syndromes can present with paraparesis and quadriparesis. Okay, quadriparesis or quadriplegia. Right. Now, I am going to talk about paraparesis and then go up to quadriparesis. Right. Okay. Now, if you get paraparesis, okay, paraparesis, upper motor neuron, where is the lesion? Most likely, where is the lesion? Paraparesis, very, very likely that the lesion is where? In the spinal cord. In the spinal cord, thoracic or lumbar. Okay, lumbar, then api matakane spinal cord deka lower limb ekata dena, what is the highest root that it gives the lower limbs? It is L1. So if you get paraparesis, the lesion should be above that highest root level. So if you get paraparesis, the lesion has to be, or is commonly in the spinal cord, in the thoracic, or basically above L1. Above L1. Okay, thoracic above L1. Upper limb එක ගිහිල්ලා නැහැනේ. එතකොට brachial plexus එකේ මොකද්ද limit එක? T1. So if you get paraparesis, the lesion should be in the spinal cord between T1 to L1. L1 වලට වැඩිය පල්ලෙහාට යන්න බෑ because කකුල් දෙක ගිහිල්ලානේ. So කකුල් දෙකට දෙන highest root is L1. So it has to be above that point. The lesion has to be above that point. So if you get paraparesis lamai, and I'll look at this very carefully, I'm going to guide you through this now. This algorithm. Dhamma patan ganna epa. So paraparesis is lesion, upper motor neuron lesion of the lower limbs. The highest root that supplies the lower limbs is L1. So the lesion has to be above that to cause an upper motor neuron lesion. At deka affected now, so the brachial plexus outflow is not affected, so the lesion has to be below T1. So lesion is in the spinal cord T1 to L1. Simple, no problem. That තේරුම් ගන්න. ඇයි L1 කිව්වේ? මොකද කකුල් දෙකම ගිහිල්ලා නිසා ඊට වැඩි උඩින් වෙන්න ඕනේ for upper motor neuron type lesion because both legs are affected. Then T1 ඉඳන් L1 වෙනකන් is a long area, is a large area. ඒ අතරට how do you localize? How we do it? The spinal cord lesion. Right. How do we know? මේ දෙක අතරට. 1. Look for a sensory level. Look for a sensory level. දන්නවනේ sensory level කියන්නේ මෙහෙම ගහගෙන ඉන්නවා නෑ දැනෙන්නේ එක තැනකින් උඩ දාන්න. That's a sensory level. It's called a sensory level. Look for a sensory level. A sensory level, if you get it, the lesion is exactly at that level. So if you get a sensory level at T10, the lesion is at T10. Here I am referring to spinal cord levels, not vertebral levels. So don't mix that up. Okay. So if you get a sensory level at T10, එතන තමයි lesion එක තියෙන්නේ. වෙන කොහෙවත් නෙවෙයි. එතන තමයි lesion එක තියෙන්නේ. Right? T10 or whatever sensory level right at that point. Right. Okay. Easy, no problem. Now we're going to make this a little bit more complicated, and I'm going to talk about quadriparesis as well now. දැන් ඔයගොල්ලෝ හිතන්න ඔයගොල්ලෝ දැන් වාට්ටුවට යනවා. වාට්ටුවට ගිහිල්ලා you get a patient to examine. You examine the patient's lower limbs, right? These patient's lower limbs are spastic, reflexes වැඩි, plantars are extensor. ඔක්කොම upper motor neuron sign තියෙන්නේ. කකුල් දෙක බැලුවා very symmetrically upper motor neuron sign තියෙන්නේ. කිසි කරදරයක් නැහැ, කචල් එකක් නැහැ, වාතයක් නැහැ. හරිද? Okay? Fine. Now what do you know? You know that the lesion should be above L1. අත්‍යර අපි තාම දන්නේ නැහැ මුකුත්. Right. Now you check sensory. Sensory is normal. මල තොප්පි සාගරය. Sensory normal. What were we expecting to find? We were expecting to find a sensory level. ඒක හොයාගත්තා නම් එතන කිව්වා close කරලා ගෙදර ගියා. හරි? close කරලා ගෙදර ගියා අපි යනවා කියලා ගියා. No problem. But now the problem is amadu sensory intact, which can happen in some types of lesions. It can happen. Sensory තියනවා. දැන් මොන මගුලක්ද කරන්නේ? දැන් මොන මගුලක්ද කරන්නේ කියනවා නම් what you do now is you examine the upper limb reflexes, and this method is called motor localization. Okay? Motor localization. If you found a sensory level, කතන්දරේ කිසිම ප්‍රශ්නයක් නැහැ. එතනින් කතන්දරේ close කරලා chapter close ගෙදර ආවා. But sensory loss එකක් නැතිකොට, so look at this algorithm, sensory loss එකක් නැතිකොට, if there is no sensory level, now what you do is you examine the upper limbs. හරි. දැන් බලන්න. Upper limbs reflexes normal. Upper limb reflexes normal. දැන් කොහෙද lesion එක තියෙන්නේ? If the upper limb reflexes are normal, the lesion has to be between T1 and L1. T1, L1, L1, T12, L1. ඒ හරියනේ එන්න ඕනේ. So lesion has to be between that area. So I'm going to revise this again. Very difficult to, obviously without judging how you understood this, very difficult, but I'm going to explain that again. Like මූණු පේනතු හරි අමාරුයි මේක මේවා කරගන්න. To gauge whether you really got this. So basically you go to the ward, you examine spastic lower limbs, no sensory level. Sensory level එකක් තිබුණා ප්‍රශ්නයක් නැහැ. So paraparesis, no sensory level. අත් දෙක අමුකුත් දන්නේ නැහැ අපි. Now what you are doing is you examine the upper limbs. Upper limbs are normal. Now because the lower limbs are spastic, we knew that the lesion has to be above L1. ඒතේ උඩින් වෙන්න එපා. ඒ කියන්නේ කකුල් වලට දෙන උඩම රූට් එක. So you go, that's fine. Because upper limb reflex are normal, you know, the lesion has to be below මොකද්ද? Upper limb reflexes වලට දෙන්නේ මොකද්ද? C5, C6 for the biceps, C6, C7 for the triceps, sorry, C7, C8 for the triceps, and C6, 7 for the supinator. දැන් අපි දන්නවා lesion එක කොතනින් පල්ලෙහා වෙන්න ඕනද? Because upper limbs are normal, we know the lesion has to be below C8 and T1 basically. ඒ ටික දැනට ඇති. තව විදිහක් තියෙනවා ඕක තව දුරටත් pinpoint කරගන්න. Right? So then T10, T1 to T12, you can further precisely pinpoint the area which you will learn later. දැම්ම නෙවෙයි උතන පොඩි clue එකක් තියෙනවා. If you are interested, you can read about that. හරි. Now take another scenario. වාට්ටුවට ගියා, කකුල් දෙක බැලුවා, කකුල් දෙක brisk. ඉතින් අපි දන්නවා මේක spinal cord lesion එකක් වෙන්න ඕනේ ගොඩක් දුරට L1 වලින් උඩ. sensor level එකක් නැහැ, මල කෙලියයි. දැන් මොකද කරන්නේ? What do you do next? Upper limb reflexes. All the upper limb reflexes are brisk. ඔක්කොම brisk. ගහන එක කන පැලෙන්න එනවා. All the upper limb reflexes are brisk. Then lesion එක කොහේ වෙන්න ඕනේද? In the upper limb reflexes, all are brisk. So again, I revise C5, C6, C7, C8, C6, C7. If the biceps reflex is brisk, lesion එක කොතනින් උඩ වෙන්න ඕනේද now? So now this is quadri නේද? දැන් උඩට යනවා. The lesion should be above C5. The lesion should be above C5. එතනින් උඩ. Upper limb reflexes and biceps and gahapu gamang awa, we know the reflexes have to be brisk there, and it's above that now. C5 වලටත් වැඩිය උඩින් තියෙන්න ඕනේ. C5 වලටත් වැඩිය උඩින් තියෙන්න ඕනේ. තව උඩට යන්න පුළුවන්ද? තව උඩට යන්න පුළුවන්. You can go up. What is the highest reflex you can check? Remember we talked about the jaw reflex yesterday? ඒක ගැහුවා. If the jaw reflex is brisk, lesion is in the brainstem, and don't worry about that from that point onwards. එතනින් එහාට ඒක ගැන කලබල වෙන්න වද වෙන්න එපා. Okay, so all reflexes brisk. We know that. Look at my mouse pointer. Lesion is above C5 and C6. Examine the jaw reflex. If that is brisk, the lesion is in the brainstem. Don't worry about that. එතනින් එහාට ඔයගොල්ලන්ට අදාළ නැහැ. Just say the lesion is probably in the brainstem above the medulla, because you know in the medulla තමයි jaw reflex එක එන්නේ. Now I'm going to teach you one more little thing now. මේකත් හොඳට අහගන්න. If the jaw reflex is normal, there is one more place where you can pinpoint it to. One more place. And that is a lesion at the foramen magnum. දන්නවද ඒක? Foramen magnum. That is where spinal cord starts. So you do the upper limb reflexes, all are brisk. You go higher up, do the jaw reflex, that is normal. Now you know the lesion has to be between the brainstem and C5. This is basic sarala logic, right? So jaw reflex is normal, then you know the reflex, the lesion has to be between the medulla and medulla and C5, somewhere there. Now there is one point where you can further localize, and that is this area, that is the foramen magnum level. If you have a lesion at the foramen magnum, you get a very actually three, but for your purposes, learn two specific physical signs. One is downbeat nystagmus. Downbeat nystagmus. ඒ කියන්නේ nystagmus බලනකොට අපි පැත්ත බලන්න කිව්වම ඇහැ යනවා උඩට පල්ලෙහාට මෙහෙම යනවා. You get a video, and there are plenty of videos on YouTube for that. Downbeat nystagmus. It goes down. කළා තවත් අමුතු එකක් වෙනවා, අමුතු සෙල්ලමක් වෙනවා. When you ask the patient to close the eyes and say play the keyboard or piano from one hand, the other hand will start moving in the same way. And that is called mirroring of movement. That is called mirroring of movement. So if you have lower limb reflexes brisk, no sensory level, that sensory level තිබ්බනම් මේ කතන්දරය ගැන බද වෙන්න දෙයක් නැහැ. No problem. If there is no sensory level, then we need to use this method, motor localization කියන method එක තමයි අපි මේ කරන්නේ. So to recap, you do the upper limbs, upper limb reflexes all are normal. You know the lesion has to be between T1 and T12. එච්චරයි දැනට. Finally එකට ආවම තව ටිකක් උගන්වන්නම් ඒක. If you do the reflexes and all the reflexes are brisk, now you know the lesion has to be above this highest reflex. The highest reflex is C5. So it has to be above that. And then you do the jaw reflex. If that is brisk, it is in the brainstem above the medulla. If it is normal, it is between the medulla and the C5 area. Okay? And there is one point which you can localize it further, and that is the foramen magnum level. Foramen magnum level, like a lesion, you get downbeat nystagmus and also the mirroring of movement. Mirroring of movement. Mirroring of movement. Hari. Good. තුන්වෙනි කාරණේ මේ මැද මේක, you examine the upper limb reflex and you get a very specific pattern. C5 C6 එක නෑ. එන්නේ නෑ. Absent. Triceps is brisk. So scenario, lower limbs are spastic, no sensory level. Examine the upper limbs, like this algorithm says, examine the upper limbs. Okay, examine the upper limbs. Upper limbs බලනකොට C5 C6 එක එන්නේ නැහැ. වල තොප්පියයි. C7 C8 is brisk. and the supinator is inverted. Supinator is inverted. That is, මොකක්ද අපි කිව්වේ inverted supinator? Commonly what you see is just flexion of the fingers when you knock there. Usually මොකක්ද වෙන්න ඕනේ? මේක නැවුණා, මේක උඩ ගියා, මේක මෙහෙම ආවා. දැන් මෙතන වෙන්නේ මේක විතරයි, or in extreme cases it goes the other way. Like that. කොහොම ගැහුවම අනිත් පැත්තට අත් සම්පූර්ණ extend වෙනවා. So loss of C5, inverted supinator, brisk triceps. තුන එකට එනවා. Then the lesion is exactly at C5 and C6. Exactly at C5 and C6. ඔච්චර තමයි ඉතින් කරන්න පුළුවන්. ඔතනින් එහාට නම් කියන්න බෑ. ওই දෙක තමයි කියන්න පුළුවන්. හරි. So loss of biceps, inverted supinator, exaggerated triceps, ඒ එකතුව lesion C5, C6. Right. Now I'm going to go through this one more time and then that is it. Okay. I'm not going to talk about cerebella and other types of packages. We'll talk about those in when you come to your final year. Okay. අදට මෙන්න මේක ඉගෙන ගත්තා නම් ඇති. Upper motor neuron package. What are the upper motor neuron signs? Spasticity, minimal wasting, increased tone, vis reflexes, extensor plantars, specific pattern of weakness, lower limbs, flexors more than extensors. Katandari hari. Hari. Then you examine hari. Paraplegia. There are three patterns: hemiplegia, paraplegia, quadriplegia. Hemiplegia ka podda pattakin tibba. Paraplegia, you know that the lesion has to be the spinal cord above L1. Spinal cord එක කියන්නේ දිග area එකක්. How do you identify the exact place? One, using a sensory level. Very easy. Sensory level එක තියෙන තැන තමයි lesion එක තියෙන්නේ. But sometimes, and especially අපි මේක දකින්න ළමයි මෙන්න මේ cervical myelopathy, මේ spondylosis වලට එන myelopathy එකේ for some odd reason sensory එක යන්නේ නැහැ. හරි? Sensory එකට මුකුත් වෙන්නේ නැහැ for some odd reason. ඒ වගේ වුණාම ටිකක් කචල්. And this is a කචල් එක පැහැදිලි කරන්න තමයි I'm using this algorithm. So you go to the ward, examine a patient, paraplegic, දැන් බලනකොට ඔක්කොම upper motor neuron signs තියෙනවා. But there is no sensory loss. Sensory loss එකක් නැහැ. Now what do? You use the motor localization method which is summarized in this algorithm. What do? Examine the upper limbs. All upper limb reflexes brisk lung, you know the lesion has to be above C5. Next you examine the jaw reflex. If that is brisk, it is in the brainstem. If that is normal, it is between the brainstem and C5. ඒ අතරතුරදී ඔය foramen magnum level එක lesion එකක there are characteristic signs, two signs, downbeat nystagmus and mirroring of movement which you can examine and see. Sorry. Then the next thing is you examine the upper limb reflexes, this middle thing. Biceps reflex absent, triceps is exaggerated, and you get the inverted supinator reflex. If you get that pattern, that combination, we know the lesion is exactly at C5 and C6. Right. Then finally, all the upper limb reflexes are normal. Then you know the lesion has to be between T1 and L1 in the cord. Okay, T1 and L1. Sorry. And that there is a way of differentiating that further, which we will learn later, which is not, now is not the time to learn that. That is basically it. So, upper limb, lower limb, physical sign interpretation. First, classify it into a package. Lower motor neuron package අනේ ළමයි මේක කටපාඩමින් දැනගන්න features of each place. That's the patterns of each place. If it's upper motor neuron, the patterns can be hemiparesis, which is most often due to a stroke, which I will just leave for the moment. There is a table here. පොඩ්ඩක් ඒක හිමින් බලන්න. දැනට හදිස්සි වෙන්න එපා. Most often stroke කියලා මතක තියාගන්න. Paraplegia, hemiplegia easily, paraplegia, quadriplegia easily localized with a sensory level. So if you have a sensory level, the level of that sensory level is the level of the lesion. No problem. And that is ගොඩක් වෙලාවට ඒක තියෙනවා බය වෙන්න එපා. But I've also given you additional information. If there is no sensory level, how do you work out? So if you get paraparesis without a sensory level, then how do you work it out? Then you go to examine the upper limbs. And then using the reflexes of upper limbs, then you classify whether it's above C5, C6, at C5, C6 or below T1. Maybe there you can classify it accordingly. The other packages we will go to when you come to your final year. You already know a cause of a mixed upper motor neuron, lower motor neuron syndrome, and that we have all discussed, that is motor neuron disease. Right? Extrapyramidal and cerebellar we will talk about later. Hari. There is a question, in a mononeuropathy, do you have to localize sites specifically where the nerve would have got damaged? Yes, if you can, that would be ideal. Say ulnar nerve, whether it's above the wrist, below the wrist, or sorry, above the elbow, below the elbow, at the wrist, take a product. Just revise your anatomy notes. They will tell you how to do that as well. But you can practice that when you come to your final, and during your second appointment, practice these things in a little bit more detail. Hari. Okay. I hope that you got this. It's very difficult for me to teach without seeing your faces, but I've tried my best to try to explain how to work out upper motor neuron syndrome, paraparesis and quadriparesis, and also how to work out a lower motor neuron syndrome and try to put it into a sub package. You have the lower motor neuron package. Within that, you're trying to say where along the lower motor neuron path the lesion is. To know that, then you also have to know the features of each place. Right. So that is it. So now I think with these 6 sessions, other product cut, I don't know whether it's a time or problem, I don't know. But make sure that everybody gets a recording of this page. I'll upload these slides as well, because this is a very important part of this whole series, is upper limb, lower limb neurology. So make sure that there are about, I know, a few people missing today, but make sure that they get the recording and the presentation. ඔක පස්සේ තමයි උඹලට ඕනේ. දැන් ඉතින් මේක අපෝ තාම මේ මෙඩිසින් සෙකන්ඩ් අපොයින්ට්මන්ට් කරලත් නැහැ කියලා දැන් ආතල් එකේ හිටියට ඔබට ෆයිනල් එක ආවට පස්සේ තමයි තේරෙන්නේ why this is important. හරි එතකොට අම්මට එතකොට දැන් කාලෙත් මදි කියලා පුක ඉරා ගන්න තමයි වෙන්නේ. So basically before that happens, make sure that you study this, use this in your second appointment. Hari, so 6 sessions we have done. First day we talked about case presentation, how to adjust your case presentation to fit your second medical appointment and your final year. Then we went through the cardiovascular system, respiratory system, abdomen, and then the cranial nerves and the upper limb, lower limb examination. First focusing on a revision of the examination technique, which you should perfect. Okay. And then an introduction to how you would analyze some of the physical signs that you are going to find in your examination. Okay. Physical signs that you're going to find in your examination. Cardiovascular, respiratory, abdomen, which is rather easy. Organomegaly. Then yesterday we talked about the cranial nerves, about how to localize a lesion along the 3rd nerve, along the 6th nerve, along the 7th nerve, bulbous, pseudobulbar palsy, optic nerve. And today we learned about upper limb, lower limb, and how to put into packages, and then how you would subsequently approach that. Hari. So Sarangani, then that's it for this part of the series. So when are you having assessments now? 17th, August.
Exams.
Yes. Then when are you supposed to start clinicals? 1 week after that?
Yes, sir, 24th.
Right. So when you finish your exams and you have a clear idea of when you are going to start clinicals, how it's going to happen, I'm not sure whether they're going to do it in the same way, group sizes, I don't know. Have you been told are there going to be any changes in how the clinicals are done, Kira?
So no, we haven't been informed the exact details, sir.
Right. So if you get to know anything, I'll obviously get to know a little bit more before you, but if you get to know anything, just let me know. And then we can plan out the next few sessions, which again about 5 or 6 sessions on just taking a few cases and try to put what we learned into practice.
Okay.
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 And so that we can do once you go to your wards, then we can select some cases out of the ward and then discuss that maybe for 5 or 6 sessions, and that will be it. And then when you come to your finals, we will discuss it in more detail.
Oh, sure, sir.
Harini? Okay.
So thank you so much for having all these sessions, sir. Thank you.
No problem. No problem, sir. My pleasure. No problem.